Well, welcome to the NephroNet lecture on focal segmental glomerulosclerosis. As for many nephrologists viewing this lecture, FSGS remains a vexing and very difficult problem. And today we're going to go over the varied pathology of FSGS, its common phenotypes, and the various types of therapeutic approaches that are available to us. So as background introduction, it's very important for the audience to remember that FSGS is really a descriptive phenotype of glomerular pathology. And what it really is a product of multiple different varied pathologic mechanisms that gives you a similar type of phenotype in the glomerulus. And so understanding that also helps to explain the variable response that we see among our patients. Various types of genetic defects can both give you a gain of function and a loss of function mutations that are increasingly detected in FSGS, including TRPC6 and others. And the problem with our current understanding of the genetic mutations is that we lack biomarkers that can accurately tell us what type of genetic background a person may have that has FSGS. And moreover, I want to talk about the prevalence that FSGS is growing, and that despite this, our ability to come up with novel therapies has been limited by this lack of appropriate biomarkers. So let's talk about the epidemiology of this very common disease. And so as I mentioned, FSGS is growing. It's between 7 and 20% of all cases of idiopathic proteinuria in both children and adults. And as you can see from this slide, that in the early 1970s, the rate of FSGS reported in the literature was just under 14%. And by the mid-1990s, that number had gone up to 35%. And in some series, in the late 1990s and early 2000s, it could be as high as 60%. It is clearly increasing cause of end-stage renal disease. And among African Americans, the rate is 2 to 4 times higher than that seen in Caucasian populations, and can be seen as much as 36 to 80% of glomerular lesions that lead to end-stage renal disease. This slide gives you another way of looking at that same data. You can look at Caucasians and others, which include Asians and Hispanics, and compared to those, patients of African descent have a significantly higher rate of FSGS as well as progression to end-stage renal disease. This remains a very difficult problem for this population of patients. If you look at individual countries, you can see the prevalence also is quite highly variable. In the United States, it's about 7 cases per million population among Caucasians. But when you look at the African Americans, once again, that number is as high as 20 cases per million population. It is comparatively uncommon among Asian populations. In France, about 12 per million population. But the country with the single highest prevalence is Saudi Arabia, with 41 cases per million population. The explanation for that is unknown. Now let's go over some of the different pathologies. As we mentioned before, that FSGS is really a response to injury within the glomerulus, typically of the podocyte. And there have now been 5 well-described different classes of FSGS. And as you see, they will be vastly different from one to the other. The most common by far is the classic, or NOS, not otherwise signified. And this is described by glomerular lesions that you can see in the darkened areas here on your screen. These are sclerotic areas where there has been capillary collapse. There has been a loss of podocytes and typically adhesions of these capillary tufts to Bowman's capsules. There can be segmental occlusion of glomerular capillaries and accumulation of extracellular matrix proteins. There can be hyalinosis and accumulation of eosinophilic fluid materials, and the proximal tubule cells in this disorder typically demonstrate foam cells, which are indicative of the high rate of protein absorption that is seen in FSGS. Another fairly common form of FSGS is the tip variant. And as you can see in this photomicrograph here, you can see that the sclerotic lesions are concentrated around the vascular pole of the glomerulus. Moreover, you might be able to appreciate that the segmental lesion is actually screwing into the proximal tubule of this particular glomerulus. There is oftentimes hypertrophy of very visceral epithelial cells that are opposite to the vascular pole. Adhesion lesions at the tip area is quite common. The tips variant is seen in about 17% of biopsies, and from a clinical standpoint, it's important to know that it's typically more responsive to steroids than other subtypes. The collapsing variant is an extremely aggressive form of the disease. It is characterized by pseudocrescence of the visceral epithelium. There is a tremendous collapse of the glomerular capillary tuft, as evidenced and shown here in this particular slide. This is, in fact, a pseudocrescent arising from the visceral epithelial cells. There's a rising incidence of this, particularly among African Americans, as noted by this demographic of approximately 11% in the late 1970s to as much as 24% in the early 1990s. Very poor long-term renal survival. About 1 year is 13% versus 62% for other forms of disease. It has been associated with pamidronate as a cause of it, and is a very difficult lesion to treat. The perihilar variant is much more common. If you see a TIPS lesion, it definitely rules out that variant of it. The sclerosis is on the periphery and the perihilar areas of the glomerulus at about 50% of the glomeruli. There's a reduction in podocyte hyperplasia, typical foam cells, and its incidence is highly variable, but on the lesser side compared to the NOS version. And lastly, there's a cellular variant. This is quite rare, about 3% of FSGS biopsies. It's actually characterized by endocapillary proliferation. There is oftentimes infiltrating PMNs and is often confused for other forms of GN, including post-infectious disorders. Now, let's talk about secondary FSGS. It's important to know that all persons with sclerotic lesions and proteinuria do not necessarily have a primary FSGS disorder. There are multiple causes of secondary FSGS. Some of them are drug-induced. For example, pamidronate has been quite highly associated with the development of secondary FSGS, as has interferon gamma, lithium, and rapamycin. Patients with reduced nephron mass or recurrent ureteral reflux also can develop subnephrotic range proteinuria due to secondary FSGS. There are viral causes, including CMV and parvo B19. Renal injury from diseases such as sickle cell anemia and thrombotic microangiopathy can also give you a secondary FSGS. Obesity itself, and we'll cover a little bit of this, is the obesity-related FSGS is a very common problem here in our state. Genetic defects, including podocytin loss, TRPC6, and also can contribute to this form of FSGS. A couple ways that you can determine, and it's very important for the clinician to know whether he's treating primary or secondary FSGS. The etiology of primary is a podocyte injury process, and that can include everything from NOS FSGS to diabetes and various types of disorders like that. Whereas secondary FSGS is a maladaptive response. Primary typically has the nephrotic syndrome, including anasarca, whereas secondary FSGS typically has lower levels of proteinuria that are often, but not always, subnephrotic in range. There is a consistent difference in the degree of footplate effacement in the podocytes. Typically, that range is in the 50 to 100% for primary idiopathic FSGS and generally less than 50% for secondary. Glomerular size can be variable in primary disease, but are typically enlarged in response to the secondary injury, and the glomerulus typically increases in size. We'll go over therapy in this disorder in more details, but in general, some form of immunosuppression is involved in the treatment of primary FSGS versus treatment of the primary disorder contributing to the secondary FSGS in conjunction with ACE or ARB therapy. Now let's talk about obesity-related FSGS. So this is a study that was published in Kidney International 2 or 3 years ago. It was to determine the pathophysiologic differences of an incidence of obesity-related glomerulopathy compared to idiopathic. This is a retrospective analysis of 6,800 biopsies performed at Columbia University, and they defined obesity as a body mass index of greater than 30 for obesity, class 1 BMI of over 35, and class 3 obesity if you have over 40 BMI. They looked at the glomerular cross-sectional area, the basement membrane diameter, and podocyte density in this disorder. Now, as always, a picture is worth 1,000 words. You can look and see that in obesity-related FSGS, there is a tremendous glomerulomegaly that is seen in this type of disorder. The left-hand glomerulus is one from a person with obesity-related FSGS compared to a normal control, and it's virtually more than double the size between the two glomeruli. Moreover, there is thickened basement membranes. There is sclerotic lesions that are shown here, and these are typical when seen in conjunction with very large and enhanced glomeruli. And as you can see also here in this electron micrograph, there are no dense deposits. The outcome of obesity-related FSGS tends to be better than idiopathic. And if you look here at the long-term Kaplan-Meier survival of this disorder, out to 96 months, there's generally about only a 70% progression toward dialysis in those patients with obesity-related FSGS versus almost 70% in those patients with idiopathic forms. So what's the natural history of primary FSGS? What can we expect? Well, again, like all aspects of a multivariate disease, it depends on the type of FSGS you have. So as I mentioned earlier, the TIPS lesion, which is oftentimes steroid responsive, generally does better. And you can again see this Kaplan-Meier survival curves in patients out to 3 years. TIPS lesions do slightly better than the classic or NOS, which does a little bit better than the perihilar. And as I mentioned previously, the collapsing variant does very poorly, with almost 70% reaching end-stage renal disease within 2 years. If you look at the response to treatment, so this is Dan Catran's paper that was published in 2005, where he looked at the complete response rates, partial response rates, or no response rates, and how that response to steroid therapy affected the long-term survival of the patient's kidneys. So you can see in the crosshatch at the top here, patients receiving a complete response did generally pretty well. Only about 10 to 15% end-stage renal disease failure rates in patients up to 15 years. Patients, however, that had a partial response clearly did better than those in the black line, which had no response. So again, this is an implication back to the clinician that any type of therapy that achieves a partial response, you generally help that patient's long-term survival. So how do we treat this? So the classic therapy has always been glucocorticoids. And a lot of this was written and published by Steve Corbett and Claudio Ponticelli. This is the Ponticelli paper that looked at a retrospective review of 53 patients receiving an initial immunosuppressive therapy with oral prednisone. These patients received a mg per kg per day for 8 weeks with a median treatment time of 16 weeks. Repeat therapy was performed in 26, or roughly half that patient population, at a mg per kg for 20 weeks and up to 69 weeks. Approximately a third of the patients refused prolonged therapy. And what you find is if you look at the initial response to therapy, here's the total in the blue. This is the percent receiving a clinical response. So about half the patients in initial therapy out to 16 weeks responded to a course of steroids. About 36% of those were complete response, 16% were actually partial response, and then of those numbers, about 32% of those had a recurrence of the disease. When the patients were then reintroduced to steroids, the response rate was significantly less. So here is the total response rate of 14.2%, of which was evenly divided between complete and partial response. Again, this gives you a clinician the idea that, in fact, steroids has some role in the treatment of FSGS. It is fraught with many types of complications and confounding problems, and that if a patient has a recurrence on steroids, the likelihood of them having a significant response is greatly diminished. If you look at the efficacy of prolonged steroids, again, this is the Ponticelli paper, you look at doubling of serum creatinine at 5 years was about 31% versus patients that had a complete or partial response versus a complete response. So again, as I showed you in the previous slide, those individual patients that had a complete response did much better over the long term than a partial response. However, partial response was met with an improved clinical outcome. This is Steve Corbett's data. This is analysis of multiple smaller trials listed in below in the bottom portion of your slide. You can look at complete response in the dark blue, partial response in the blue crosshatch, and the red data is no response. And pretty much across the board, there is about a 30 to 40% response rate when, in Dr. Corbett's recommendations, the therapy was prolonged out to 16 weeks. There was remarkable similarity between all 4 of these different studies. And so, again, it gives you the idea that approximately 30 to 40% of patients will respond to either complete or partial response with prolonged steroid therapy. So the KDIGO recommendations are as follows. The initial treatment of FSGS, immunosuppressive therapy only in those patients with clinically relevant nephrotic syndrome. Corticosteroids at 1 mg per kg per day for a maximum of 80 milligrams for a total of a 16-week period of time should be achieved and in place before determining the patient requires additional therapy. The corticosteroids should be then tapered slowly over 6 months after achieving a complete or partial response. Calcineurin inhibitors would be the first-line therapy for those patients that have relative contraindications or intolerance to oral steroids. Okay, what about the second-line therapy that is common for most people, the calcineurin inhibitors? There's quite a bit of data published on this. This goes back a number of years. This is the Gregory paper that was published in the mid-1990s. This was a study to establish the efficacy of cyclosporin therapy in children with steroid-responsive nephrotic syndrome and determine the incidence of cyclosporin nephrotoxicity with long-term therapy. This is a prospective, open-labeled study of long-term treatment, 21 months, with cyclosporin in 22 children with steroid-resistant nephrotic syndrome. Children were treated for 4 to 8 weeks with a course of steroids, resistant or intolerant, and then added cyclosporin at 6 milligrams per kg per day, attempting for a trough level between 70 and 120 nanograms per mil. The children then, if were willing, underwent a repeat biopsy after their therapy was completed at an average of 21 months. So you can see here the complete response rate was quite good. So 85% of the patients had a complete response, another 13% had a partial response, and the time to that response was generally about 2 months, and that's certainly been my experience. The histologic subtypes that responded the best, all of the children with steroid-responsive FSGS responded. About 93% of the children with IgM responded, and a slightly less, at 66%, with minimal change glomerulopathy. Dan Catran also did a very important study. This is a randomized, single-blinded prospective study that was placebo-controlled in 49 patients with FSGS that had failed steroid therapy for at least 8 weeks. The MD was unblinded. Patients were then given 3.5 mg per kg, again attempting for trough levels between 125 and 225 for a duration of 6 months with a follow-up out to as far as 105 weeks. Complete remission was defined by Dr. Catran as less than 300 milligrams per 24 hours. A partial response was a 50% reduction if that level was below 3,500 milligrams of protein. And again, you see a pretty decent response rate. So here's partial response in the blue. Not quite as vigorous what you saw with the children. The complete response was in the black, and then the placebo response rates was in the red. So you can see on average about a 62% response rate at 12 weeks. When the patients were followed out to 26 weeks, the response rate was approximately 68%. 52 weeks, it had fallen down to 38%, and so forth. Out further into the follow-up, there remained fewer patients in complete or partial response rate. But during the first 6 months, a rate between 60 and 65% was very commonly seen with the course of oral cyclosporin. If you then looked at the percent of patients with a 50% decline in creatinine clearance, those patients in the placebo were much higher as time went throughout the follow-up of the study, and cyclosporin clearly stabilized renal function over the course of time. Well, there's other calcineurin inhibitors. My personal preference has been tacrolimus for a number of years. This was a study to look at, again, adult-onset steroid-resistant FSGS, and the objective of the study was to determine the safety and efficacy of long-term tacrolimus in the treatment of steroid-resistant FSGS in adults. It's a prospective study, observational trial of 44 steroid-resistant patients. A renal biopsy had to have been performed in these patients within less than 1 year and failed a 16-week course of steroids. Tacrolimus was given at 1 mg per kg, 0.1 mg per kg, attempted for trough levels between 5 and 10 nanograms per mil. Treatment was for 24 weeks. Follow-up was for 24 weeks after the reduction in dose. Similar definition of a complete or partial response, less than 300 milligrams per 24 hours, and then a 50% reduction in protein. So as you can see, not quite as vigorous in this particular trial Complete response rate was approximately 39%, partial response around 14%, giving you roughly a 50% response rate. The time to that took about 107 days. When you break down the histologic types, the TIPS lesions typically were more responsive, more or less equivalent with the NOS form, and the cellular variant, as typical for most reported series, was less responsive to any form of therapy. So, is there an advantage to using tacrolimus over cyclosporin? There are some. Tacrolimus versus cyclosporin in a children's study looking at steroid-resistant nephrotic syndrome was performed by Chowdhury's group. This was published in 2009, and it was a randomized prospective comparative study of cyclosporin and tacrolimus in 41 children with steroid-resistant nephrotic syndrome. FSGS in this study was about 40%. Patients received 5 milligrams per kg of cyclosporin versus 0.12 mg per kg for tacrolimus. Trough levels are similar to previous trials. Again, 6 weeks of therapy with a prolonged follow-up. A little bit more different, rigorous definition of complete response, less than 200 milligrams in this study, with a partial remission between 200 and 2,000 milligrams of protein. And as you can see, the response rate was similar for both drugs. About a 70% response rate for both calcineurin inhibitors at 6 months, and the Kaplan-Meier curves were virtually superimposable. So in this study, there was no significant benefit to cyclosporin over tacrolimus or vice versa. In my personal opinion, I believe that the fibrotic and comorbid complications of tacrolimus are slightly better. But as in all cases of clinical medicine, there will be patients that will tolerate one drug that will not tolerate another drug. And by switching between the two individual agents, you can achieve a decent drug therapy. Okay, some of the mutations, we alluded to this earlier in the talk. One of them I do want to talk about is the TRPC6 mutation and its particular relevance in the usage of calcineurin inhibitors. Let me describe this to you. So TRPC6 is a calcium channel that in patients, many patients with FSGS had the development of a gain of function mutation, leading to a chronic influx of extracellular calcium into the podocyte. Now, just to remind you of your biology, rising intracellular calcium levels in any cell can activate calcineurin, which is a calcium-dependent serine-threonine phosphatase. It turns out, by a number of studies, that calcineurin actually is a phosphatase for the structural protein of synaptopodin. When synaptopodin is phosphorylated, it is a more stable peptide and resistant to degradation through binding to other proteins like 14-3-3. In the gain-of-function mutation with TRPC6, the constant activation of calcineurin leads to a dephosphorylation of synaptopodin and thereby, proposed by many basic science investigators, a destabilizing effect on the cell cytostructure of the podocyte. Therefore, the giving of a calcineurin inhibitor like cyclosporin and tacrolimus to these patients with a known TRPC6 deficiency can in fact be the drug of choice for this particular patient. In fact, when it is known that a patient has the TRPC6 deficiency, this would be first-line therapy in our opinion. Now, what about the combination of steroids and other agents, particularly mycophenolate or cyclosporin? This has been also looked at. This is a paper published a couple years ago attempting to determine the efficacy of combination mycophenolate and cyclosporin reducing proteinuria in children with steroid and cyclosporin-resistant nephrotic syndrome. This is a prospective observational study of 23 patients with steroid-resistant nephrotic syndrome. The primary therapy was prednisone at a mg per kg for a 6-month period of time, with or without cyclosporin A. And then for secondary therapy following steroid withdrawal, the patients were treated with cyclosporin with the addition of MMF for an additional 6 months. Complete response remission was protein less than 4 milligrams per kg per day. A partial response was a 50% reduction. So again, the dark blue is complete response, the light blue is partial response, the no response is in red. And you can see that about 32.8% of the patients with prednisone and cyclosporin achieved a complete response. However, in the mycophenolate group with cyclosporin, that number tended to be higher at 47.8%, partial response rates were equivalent, no response rates were equivalent. So there can be some benefit to the addition of mycophenolate to cyclosporin, and combination therapy is a mechanism for treatment that is going to become more common. And I'm going to show you some of our own data in just a few minutes looking at combination ACTH and tacrolimus. Well, this is also a study looking, this is Ron Hogg's paper published in 2013. This was a prospective randomized open-label comparator trial of 138 patients with biopsy-confirmed primary FSGS. Cyclosporin at 5 mg per kg for a maximum of 250 was 1 week treatment wing, and dexamethasone with mycophenolate mofetil at 0.9 and 25 to 36 milligrams per kg for the MMF. Similar definitions of complete and partial response. And as you can see, this is cyclosporin-induced protein reduction at 72 weeks. This is an NIH-funded trial. Cyclosporin, very similar numbers, achieved about 54.2 complete or partial response rate at 6 months. The mean proteinuria was 240 milligrams per day. However, if you compare that to the dexamethasone and mycophenolate, clearly the cyclosporin was the winner. 39.4% of the patients achieved complete or partial response rate, and the mean proteinuria at the end of the study was significantly higher in the DEX and MMF group compared to the cyclosporin. Again, so here's an example where the combination therapy did not add anything more to what cyclosporin therapy can do alone. Moreover, and one of the driving reasons for looking at this question is the legitimate concern that calcineurin inhibitors can induce a primary nephrotoxicity over time and lead to a reduction in renal function. You can see that there was a 19.4% in estimated GFR at 1 year of therapy with cyclosporin. There was a 7% increase in GFR in the DEX and MMF group, and that this effect persisted for the entire follow-up. However, it should be emphasized that after the weaning of the cyclosporin, there was near complete recovery of the loss of the GFR, most likely representing the hemodynamic effect of these drugs as opposed to permanent nephrotoxicity. So how common is this problem? If we treat our patients with this, how often do we develop cyclosporin or tacrolimus-induced nephrotoxicity? So this was the Meyer papers published in 1994. This is early on in the usage of these agents. It was a study of 36 patients with steroid-resistant and dependent minimal change or FSGS. So there was 22 minimal change in 16 FSGS patients. Cyclosporin was treated at 5 mg per kg per day with a maximum dose of 250 twice a day, and the duration was quite variable between 6 and 78 months. A pre- and post-renal biopsy was done on average of 20 months in between therapies, and the change in GFR and histologic changes was compared between renal biopsy 1 and 2. So you can look, again, a picture's worth 1,000 words. So here's the glomeruli, here's the typical tubular structures. You see a small degree of fibrosis indicated by these sclerotic lesions, and then you compare this to severe cyclosporin nephrotoxicity, and you see the classic stripe fibrosis that it was seen in these patients. So this is after a mean of approximately 24 months. In my personal experience, this can be very highly variable, but it is a very legitimate concern, and we should do our best to try and wean people off the calcineurin inhibitors when clinically feasible. When he further dissected this, the evolution was 7 of 22 patients, or 31%, progressed in their FSGS morphology. The development of contrast nephropathy at 20 months was 2.8% senescent glomeruli, and 12.71% of the glomeruli after 20 months had become globally senescent. Tubular atrophy in the minimal change was 26%, but I would point out to the audience that the FSGS was significantly more susceptible to tubular atrophy and interstitial fibrosis when compared to the minimal change patients. Again, so this needs to be a consideration when choosing long-term consolidated therapy in our patients. All right, the newcomer on the block is ACTH. And this is actually an older drug that's been around for a number of years, but it's only been recently been reactivated since the late 2000s. So let me remind you a little of the biology. It has been well established, and I'll show you some data in a moment. that the melanocortin-1 receptor, of which there are 5, is expressed in the glomerular podocyte. The receptor is a very typical 7-membrane spanning G-protein coupled receptor that leads to the activation of adenylate cyclase, the generation of cyclic AMP, and ultimately the activation of protein kinase A and other types of cyclic AMP-dependent pathways. And I would also point out that analogous to what I mentioned to you previously with cyclosporin, it turns out that synaptopodicin is also a substrate for protein kinase A. So when phosphorylated, the synaptopodicin, as I mentioned previously, is less susceptible to degradation following its phosphorylation. Therefore, there is the very real possibility that there could be an acute and rapid effect of ACTH on stabilizing podocyte function. So let's talk about the receptors. So this is the Lenskog paper that was published in 2010. And this asked the question of whether melanocortin receptors are in fact expressed in human renal tissues, particularly the podocytes. And they did this by looking at primary cultures of podocytes, tubular epithelium, and glomerular endothelial cells, and then co-localizing MCR1 with synaptopodin antibodies and doing immunofluorescent confocal microscopy. And that's an example of what this is. So in the green, the antibody is staining for the MCR1 receptor, whereas the red is staining for the synaptopodin protein. You combine the two images and you can see that in fact the MCR co-localizes with synaptopodicin in the glomerular podocyte. You also see that in tubular cells where there is emerging, and in fact the MCR is also expressed in the tubular epithelium. So this started to be looked at by a number of groups. This is the Hogan paper. It was published in 2013. And it was determined the safety and efficacy of ACTH in the treatment of steroid-resistant FSGS. It was a prospective open-label study of Acthar gel in 24 patients, of which 22 are steroid-dependent and or resistant FSGS. It was performed at 2 academic medical centers. There is the Stanford regimen and there's the Colombian regimen. They differ slightly. In the Stanford regimen, the 40 units was given sub-Q weekly for 2 weeks, followed by sub-Q 80 units sub-Q weekly, and then ultimately the standard dose of 80 units sub-Q twice a week for an additional 16 weeks. The Columbia regimen, Andy Bomback's group, did 40 units sub-Q for 2 times per week for 2 weeks, and then 6 months of 80 2 times a week. Definitions were standard, less than 500 milligrams of protein for complete response, and then a 50% reduction in protein. So if you look at the various types of histologic types, so when this is looked at, the TIPS variant was seen in about 45% of these patients, the NOS or classic at about a third, the cellular variant at about 16%, and 4.2% had collapsing variant. Of these patients, 87% have been treated previously with steroids, 71% have been treated with calcineurin inhibitors, a little bit, about half, about MMF, and then others, including rituximab. And you can see is the response rate was marginal. The complete response and partial response rate was about 5 of the 12 patients in the Columbia data, giving a mean drop in proteinuria from 6,800 milligrams, 6,900, down to about 5,500 milligrams per deciliter at the end of treatment. The Stanford data was similar. About 3 of 11 received a complete or partial response rate, dropping from 4,689 down to 3,900 milligrams at the end of their therapy. If you look at this, this is an analysis of previous studies, including the Hogan paper, and you can look at various subtypes: FSGS, idiopathic membranous, IgA, and diabetic nephropathy. The red data is partial remission. The black data was no response or early termination. And you can see that a partial remission was seen in about 50% of FSGS, slightly less of membranous. That's not been my experience, quite frankly. IgA at about 20%, and the no response rate ranges broadly from as little as 30% to as much as 60%. So that led Dr. Brad Robin and myself to consider doing a trial of combination Acthar gel and tacrolimus. Now, let me use my diagram to remind you of what we believe would be a physiologic mechanism of why combination therapy would be very efficacious in this population. Again, I mentioned to you that both that the synaptopodicin is a substrate for both calcineurin inhibitors, calcineurin, as well as protein kinase A. Therefore, if you gave a drug that simultaneously, or a therapies that simultaneously blocked the dephosphorylation of synaptomycin via cyclosporin and tacrolimus, and you stimulated the phosphorylation via the protein kinase A pathway, you may have the effect of additively stabilizing synaptopodicin by hyperphosphorylating the protein. With that as a potential backdrop, we did a study of 23 patients with multiple forms of steroid-resistant GN. The idiopathic membranous was seen in about 35%. FSGS was seen in about 25%. Of that, TIPS invariance was 13%. We had 3 patients with fibrillary GN, 2 patients with IgM nephropathy, and 1 patient with class 5 lupus nephritis. Patients received excuse me, ACTH at 80 units sub-Q 3 times a week for a 6-month period of time. And for those patients that had a partial response or no response, tacrolimus was added between 1 and 3 milligrams twice a day, achieving a trough level between 5 and 10 nanograms. The rationale is that we would give 6 months of therapy for the ACTH with the hope of achieving complete response. If not, those with partial response or no response had tacrolimus added. And so here's the path breakdown that I've shown you previously. About 34% were idiopathic membranous, 26% were FSGS, 13% were TIPS lesions, fibrillary IgM, and lupus nephritis. Very similar. These were very resistant patients. Steroids was seen in 85%, calcineurin inhibitors at 83%, cyclophosphamide was seen in 17%, rapamycin in about 9%, MMF at also about 9%, and a smaller percentage of patients had received rituximab. So here's how this data breaks down. So the red is no response, the light blue is complete response, the dark blue is a partial response. You can see that about a quarter of the patients, maybe 30% of the patients, did not respond to the combination therapy. The complete response rate was 13%, going up to a 52% for a total of approximately 65% complete or partial response rate. When you broke this data down into the FSGS and membranous components specifically, you see that about 18% achieved complete response, 45% a partial response. Membranous was 11% and 66% respectively. So the membranous patients in this series did a little bit better than the FSGS patients. So then if you track the individual data, you can see that in fact here's the baseline at the time of presentation to the nephrologist, had approximately 6,800 milligrams of protein. The peak level of protein in this patient in aggregate was just about 11,700 milligrams. At the time the ACTH was started, the mean proteinuria was 8,200. After 6 months of ACTH, it fell to 3,600. And then an additional 6 months with tacrolimus, there was a further drop to 2,322. And that number was statistically significant. Complete response rate was 15%, partial was 65%, no response rate was 15%. Now, if you look then at the patients with membranous, you see an aggregate baseline number of around 7,600, rising all the way to a mean peak level of just over 14,000. At the time the ACTH was started, it was 10,500 milligrams of proteinuria, very severe disease, dropping by 50% to 5,900, and at the end of 6 months of tacrolimus, the number had fallen all the way back down to 2,077. This is the current levels after the drugs had been weaned. So our complete response rate was 37%, partial response rate was 62%, and the mean response rate was 12.5%. If you then look at the FSGS patients, you find a similar phenomenon. 6,700 milligrams at baseline going up to 11,400, 8,500 at the time the study was started, dropping to 3,700 after 6 months of ACTH. A further drop with tacrolimus down to 1,283. That number was significant, and the current value of this patient is at a protein level of 2,500. So what this clearly demonstrates to you, if you look at the total FSGS and membranous patients, here's the ACTH data alone. There's the complete or partial response rates. When the tacrolimus was added, there was a significant increase in the response rate, particularly among the membranous patients, from an aggregate of 33% with ACTH alone to almost 78% with the addition of tacrolimus. And we would argue that combination therapy based on this data has a plausible physiologic reason for proceeding, as well as an encouraging early clinical response rate. The other kid on the block that's always out there is rituximab, very interesting agent. Rituximab turns out cross-reacts with sphingomyelinase phosphodiesterase acid-like 3B protein, or SBMPDL-3B. This particular molecule is stabilized with the addition of rituximab and stabilizes podocyte function again at the level of synaptopodin. The data is somewhat controversial. If you look at rituximab in adult patients with steroid-resistant FSGS, this was a prospective study of 8 patients with pediatric disease that were in the Glossin trial. The response rate was 5 of 8 had no response, 1 had a transient reduction in proteinuria, and 2 had sustained reduction in proteinuria. Overall, not terribly encouraging. 5 of 8 response. There was a drop in proteinuria in some of the patients, but again, this will need to be studied further before it becomes a standard of care. When you look at all the studies on this, is a very nice compilation of multiple small trials looking at minimal change in an FSGS, and this is a response to rituximab. Again, the minimal change seems to do a little bit better, about 68%, with FSGS patients having a less vigorous response at an aggregate of 45%. Lastly, we'll give you a look around the corner. This is fresolimumab, which is an antibody designed to recognize all 3 isoforms of transforming growth factor beta. This was published by the Genzyme study. We presented this as a late-breaking trial last year at the ASN. And what we found was, if you look at patients at the 1 milligram per kg dose, about 4 of the 14 patients in the trial responded by a partial response. When you went up to the higher dose of 4 mg per kg, effectively no different, 2 out of the 12 or 17% response rate. But what is quite interesting is that it did appear to stabilize GFR function over the course of a prolonged follow-up and appeared to be particularly effective in patients with a collapsing variant. Again, these data will need to be repeated and corroborated, but possibly, again, illustrates the point that different types of therapy may be required for different subsets of FSGS. So again, alternative development therapies underway include fresoluzumab, abatacept, adalimumab, and pirfenidone have all been looked at as possible therapies. First-line therapy remains glucocorticoids at 1 mg per kg per day for 16 weeks. Be very careful of weight gain, steroid-induced diabetes, avascular necrosis, psychiatric complications. We find this to be very difficult and problematic in our personal experience. Second-line therapy is either cyclosporine or tacrolimus with or without combination of prednisone. Third-line therapy can be tacrolimus, rituximab, Acthar gel, tacrolimus with Acthar gel, in some combination. This is a fruitful area where combination therapy could be efficacious. Minimally efficacious drugs would include mycophenolate and the mTOR antagonist. Future therapies include fresolimumab and pirfenidone. So in summary and conclusions, FSGS is a descriptive phenotype reflecting a pathologic reaction to podocyte and glomerular injury. We need to develop biomarkers that will help the clinicians to know what is the pathophysiologic pathway that we would specifically design to treat for an individual patient. We simply don't have that at this point, and there's a lot of work going on that. I think that stabilizing podocyte function by whatever mechanism you do will have a positive outcome in FSGS, and combination therapy with drugs like ACTH and other agents may in fact be able to accomplish that. I thank you for your attention.